and welcome to the NRMN Health Research Talk. I'm Ann Smith. Today we'll be talking with Dr. Raegan Durant. Dr. Durant is Associate Professor of Medicine with UAB Division of Preventive Medicine. He will be talking to us today about health disparities and research design and methods. Welcome, Dr. Durant.
Great, glad to be here.
What will we be learning in this talk?
So today we're going to talk a little bit about research design for health disparities research. And we're going to start talking a little bit about elements of research design and then design and implementation of a research project, the characteristics of measurement, causal inference. We're going to then go over a fairly detailed review of different study design types. And then finally, we're going to talk a little bit about community-based participatory research. So with that, why don't we go ahead and get started? So first, I'd like to talk a little bit about a definition for health disparities. This slide is a graphic taken from the seminal paper commissioned by the Institute of Medicine, Unequal Treatment, dating back to 2003. And what the slide depicts is a definition of health disparities. On the left-hand side of the slide, specifically the y-axis, there's a measure of quality of health care. And you can see the two bars, the white bar and the gray bar, demonstrating lower quality of care among minorities relative to non-minorities. And the difference in the heights of those two bars represents what potentially could be a disparate outcome. And when we look more closely, though, those differences could be due to, in that first box, variation in clinical appropriateness or need and patient preferences. In the middle box, it could be due to more structural or institutional causes for differences. And then finally, in the last box, it could be due to more person-level factors such as discrimination, bias, stereotyping. And it's really these last two boxes, the institutional level factors and the person-level factors, as opposed to patient preferences or clinical appropriateness, that account for disparities. So I just want to make sure that we're all on the same page when we talk about disparities moving forward in the talk. And more broadly, disparities oftentimes refer to racial and ethnic differences, and those are the most common contexts in which we look at disparities. But they also describe differences according to other characteristics, gender, socioeconomic status, geographic location, disability status, or special health care needs, as well as sexual identity and orientation. And oftentimes, analyses of disparities don't focus on just one of these factors, but oftentimes these analyses take into account many of these factors simultaneously. Now I want to talk a little bit about the elements of research design. And these elements are listed in this table in the leftmost column, and then the purpose of each element in the middle column. And then what I've tried to do is sort of adapt or give examples of these elements given a context of a research question based on whether or not physical activity is associated with hospitalization rates among persons with heart failure. So you see in that first row, we're looking at the research question as the element, and then what the purpose is, sort of what questions will the study address? And as I just mentioned, as an example, one question may be, is physical activity associated with hospitalization rates among persons with heart failure? That second element in the second row is background and significance, and it basically pertains to the notion of why we even care. Why are these questions important? And as an example, in the context of the study example that I used, heart failure is the most common reason for hospitalization among Medicare beneficiaries. So because it's a very prevalent disease and hospitalizations occur frequently, we are interested in it, and it's probably worthwhile to study. And the next element, design, and it includes time frame and epidemiologic approach. So how is the study structured? And so in the example, this could be, will physical activity be measured prior to assessing hospitalization rates for heart failure, or will it be measured among persons who already have heart failure? And then the additional elements include subjects, variables, statistical issues, and in those instances, they're relatively self-explanatory in that subjects are the people that will be in the study. the variables are the factors or characteristics that will be measured, and then statistical issues pertain to how the data will be analyzed. And I've given examples here, I won't go through all of them, but how those things can be measured in the context of the research question around physical activity and heart failure as well.
So Dr. Durant, once all of these elements of study design are developed, identified, how does a researcher go about developing the plan to answer the research question?
So there is a somewhat systematic way in which investigators can assemble all of the elements into a sound research design. And this slide, entitled Design and Implementation of the Research Project, gives an overview of that, and I'll sort of walk you through the schematic. On the bottom row is where we all start when we're thinking about a research project, and it's the design and implementation phase. And the first step is coming up with a research question, and then based on that research question, we will try to design a study plan, and based on that study plan, then we will try to implement an actual study. At these two steps, between first the research question to the study plan, we are trying to maximize something called external validity. In other words, to what extent does our study plan represent a true assessment of the phenomenon of interest? So for instance, with the example of physical activity and heart failure, we want our study plan to really reflect an analysis of the relationship between those two factors, and that really is how we would characterize external validity.
Okay.
In the next step, going between study plan and actual study, that really is a place where we'd like to maximize internal validity. And that internal validity refers to our ability to actually measure the things that we set out to measure. So once we have a plan, the way in which we implement the plan, we hope that that reflects what we truly set out to measure, and we hope that the relationships that we find among factors represent the relationships that we set out to assess. So once the study is done, so moving to that first row above the dotted line, we see findings in the study. And from those findings, we draw inferences or we draw conclusions, and we come up with some, what we think is truth in the study. And then we may be able to draw even broader conclusions or inferences about the extent to which the truth that we find in the study represents truth in the universe. And that summarizes the drawing conclusions phase. And that's in essence how we go from the design and implementation to drawing conclusions from a study.
Very helpful.
So in the next slide, I actually want to focus a little bit on the first part of the pathway that I just described, and that is the design and implementation phase. And you'll see that highlighted on this slide, in essence going from research question to study plan. And as I mentioned, this is a place where we really want to maximize external validity. And it's a place where we are vulnerable to some error being introduced. And so this slide depicts pictorially that effort to go from the research question to the study plan. So as I mentioned, we hope that ultimately we will have some assessment of some scientific truth in the universe. And we start with our research question, and we have based on that, we have a target population and a phenomenon of interest that we are measuring. And from that, we come up with a study plan, which represents the intended sample, as well as the intended variables or measures that we will be looking at. And in the process of going from the research question to the study plan, there is an opportunity for introduction of random and systematic error. And that, of course, would tend to erode our external validity. It may be a little bit more easy to describe using a concrete example. So going back to the example of physical activity and heart failure, if our research question is whether or not physical activity is associated with hospitalization rates among persons with heart failure, we would want to identify persons with heart failure, and we'd want to identify persons with physical activity. And so the way we might implement that in a study plan is to identify patients seen perhaps in an academic heart failure clinic. And the way we might measure physical activity is by asking them to keep a diary of physical activity. And that's an example of that transition. And we'd hope to minimize the random and systematic error in that transition. Mm-hmm. In terms of the next steps in design and implementation of the research project, I'd like to now focus on the transition from study plan to actual study. And remember, it's in this step that we're trying to maximize internal validity. And going back to a similar schematic that we used previously, we're going from the study plan, which informs the findings of the study. And on the left, we have an intended sample that we plan to recruit and intended variables that we plan to measure. And from there, we will go to an actual sample that we actually recruit and actual variables and measures that we are analyzing. And to the extent that the actual sample and variables are different than the intended sample and variables, there's some introduction of random and systematic error. Again, we try to minimize that. Using the same example that we used, we might set out to identify patients in an academic heart failure clinic, and we would like to use a diary of physical activity to measure their physical activity. Ultimately, the heart failure patients that we might enroll would be the ones who agree to participate. They may or may not be representative of the broader sample in the academic clinic. And we would obviously set out to have a diary of physical activity, but the only information we'd have to go on is what's recorded in the diaries of physical activity. So to the extent that it might be recorded unevenly or inaccurately, those are examples of bias potentially being introduced there. This slide really summarizes that whole pathway again, this time with the same layout. Below the dotted line, we have a target population and a phenomena of interest. We implement study design. In that step, there's introduction of random and systematic error. And then again, we go from an intended sample and intended variables, and we implement that study design, and we get actual subjects and actual measurements. There's an opportunity for internal validity to be compromised here, again, through random and systematic error. To the extent that we can minimize the compromise to validity, and on either step, we have a better ability to draw inferences about the findings of the study, to identify some truth, and then hopefully even to extrapolate about a broader scientific truth in the universe.
After deciding on the study design, how does a scientist determine what measures to use?
Well, that's a great question. So one of the things that we do after deciding on the design is then really think about what types of measures would be best to help us examine or explore the phenomena of interest. And some of the places we start is just looking at categories of measurements. And this slide makes some delineations between measurement scales. And on the leftmost column, we have different types of what we call categorical measurements. And categorical measurements are those measurements that have some sort of groupings, or as the name might suggest, categories that participants may fall in. So there are two main types of categorical variables, nominal and ordinal. And in the nominal type, typically they're unordered categories. Examples include gender, blood type, vital status, so whether or not someone's alive or dead. And the statistics usually in these categories are based on absolute counts or proportions or percentages. And the information content oftentimes is lower because they're less granular distinctions, and more times than not, they're just broader categories that people are falling into. The other type of categorical variable is an ordinal variable, and these are categories that are ordered in intervals that aren't quantifiable. So for instance, a pain scale that measures degree of pain is an ordinal variable. If you ask someone, tell me what your pain is today on a scale of 0 to 10, 10 being the worst pain imaginable, That's an example of an ordinal scale. The nice thing about ordinal scales is it does lend itself to identifying medians as well as counts and proportions, similar to the categorical scales. And the information content is intermediate. It's a little bit more than categorical, but not as much as the last category, and those are continuous or ordered discrete scales. And these are scales with ranked spectrum with quantifiable intervals. So very basic examples include weight, number of cigarettes per day. All of these things are quantifiable and can very easily be ranked, in addition to all the information that can be gleaned from categorical scales. Continuous scales lend themselves to calculation of means as well as standard deviations. And this really does give you the highest information content of all. And when we think about other characteristics of the scales that we'd like to use, precision and accuracy are two characteristics that come to mind. Precision is the degree to which a variable has nearly the same value when measured several times, whereas accuracy is the degree to which a variable actually represents what it's supposed to represent. So we assess precision by comparing repeated measures and making sure they are roughly the same. And we measure or assess accuracy by comparing measurements with some reference standard. And the best way perhaps to depict the difference between precision and accuracy is in this pictorial. We have a series of bullseyes here. And in the leftmost bullseye, we have good precision, so you can see those dots are clustered. So each time something was measured, it was roughly the same, but it's not very close to the bullseye, so it's deemed to have poor accuracy. In the second example from the left, there is poor precision because they aren't close together, they're scattered apart, so different measurements gave you different results. But they are deemed to be accurate because they are all hitting in roughly the same place on the target. In the third circle, that's ideally what you want, good precision and good accuracy. The precision is good because they're all clustered together, and the accuracy is good because they're all in the innermost circle on the bullseye. And then finally, the least ideal scenario is poor precision and poor accuracy, where none of them are together and they're not hitting in the same place on the bullseye. And additional characteristics include validity of measurements. We talked a little bit about this before in terms of internal versus external, but these are even broader types of validity that we assign to certain measurements. In general, it can be defined as type of accuracy describing how well the measurement represents a phenomenon of interest. We have content validity, and there are two types, face validity. And this in essence is the ability to look at a measurement or a question and feel comfortable just in looking at it or reading it that it measures what it is you're trying to look at. And then there's also sampling validity. And this refers to whether the measurement incorporates all or most of the aspects of the phenomenon under study. There's other types, including construct validity, which looks at whether or not the measurement assesses all of the components of the phenomenon, and then criterion-related validity, which looks at the measurement relative to other known measures of the same phenomenon. I think the most important thing to remember, in addition to different ways of assessing validity, particularly for health disparities, is when we're studying population subgroups, it's helpful to have a measure of interest that's been validated in that group. So oftentimes, measures are developed and they may be tested and validated in majority populations, but it's also very important to make sure that those measures are validated in the subgroup of interest, so you can make sure that you have the highest level of validity when interpreting the results.
That makes sense.
So a few other measurement issues that I'll go through very briefly. Sensitivity is the ability of a measure to detect differences in the characteristic that are important, and then specificity represents only the characteristic of interest. It's specific to that characteristic. You also want the measures to be appropriate to the objectives of the study or the potential mechanisms underlying the relationships of interest. It's good for measurements to have good distribution of responses. If you're going to be looking at differences, particularly in health disparities research, looking at differences between groups, you want to make sure that there's enough of a gradation of responses so that those differences can be identified. And then finally, objectivity. You just want to make sure that in the process of administering or analyzing the data from certain measures, that as scientists, we can be as objective as possible.
So once you have all the right measures, how does a scientist go about determining if a cause-effect relationship may be present?
So causal inference, or our ability to draw conclusions about whether or not there's a cause and effect relationship present, is very important. And while we have some guidance in terms of how confident we can be about a causal relationship actually existing, oftentimes it's very hard for us to prove it definitively. But we do have some guidance to try to decide about the likelihood of a true cause and effect relationship existing. So this table on this slide actually looks at some of the explanations for what appears to be a cause and effect relationship. So in the first explanation, it could be chance, or what we would otherwise call random error. And it's a spurious association. And in the example that is used in this table, looking at whether or not coffee drinking is related to myocardial infarctions or heart attacks, the result would really be that coffee drinking and MI are not related, even though there may be some appearance that they are. In the second explanation, it's bias. So there could be some introduction, in this instance with bias, of some systematic error. But this too is a spurious association. And the same result is present here, and that is that coffee drinking and MI are not truly related. The third explanation is an effect cause. So this is sort of the converse of cause and effect. And it may be a real association in terms of the type, but what it means is the relationship actually operates in reverse in terms of cause and effect. So it's not that coffee drinking causes MIs, but instead in this example, MIs may be a cause of coffee drinking. The fourth explanation is confounding, and that's probably the explanation that we grapple with the most when we are conducting research. It does represent a real association, but what's really going on in the presence of confounding is that coffee drinking may be associated with some third extrinsic factor that is the cause of MI. So for instance, if we found that coffee drinking was more closely related to, or also closely related to, cigarette smoking, and it really is that cigarette smoking is what's driving the MIs or heart attacks, it could give the appearance that coffee drinking is causing the outcome, but in truth, and based on hordes of biological data, we know that cigarette smoking is by far the more likely cause of heart attacks. The last explanation is a true cause and effect relationship, which would obviously suggest that coffee drinking is a cause of MI. And those are the relationships that we are trying to identify. There are a few other things that influence causal inference. One of them is consistency and strength of the association. So if we have multiple studies that consistently demonstrate a particular result, that gives us more confidence that there's a true causal relationship there. And the example that we used earlier, looking at the relationship between physical activity and hospitalization rates, if we have multiple studies showing high levels of physical activity lead to low hospitalization rates, that may provide more credibility that it's a true cause and effect relationship. Another aspect that we look at is the dose-response relationship. And what this means is that if there is a particular level of a certain factor or volume of a certain factor, then that is proportionate to the level or volume of the outcome. So again, going back to the physical activity and hospitalization for heart failure question, if high levels of physical activity lead to the lowest levels of hospitalization rates, that may give us confidence. In parallel, intermediate levels of physical activity may lead to intermediate hospitalization rates. So it's that dose-response relationship that may make us feel more comfortable drawing a conclusion about cause and effect. And then finally, biologic plausibility. So does it make sense, using the same example, that higher levels of physical activity lead to lower hospitalization rates? If we find something that biologically doesn't make sense, we're probably less inclined to draw conclusions about whether or not it's a true cause and effect relationship. Now I'd like to talk a little bit about different types of observational studies. And these include cross-sectional, case control, and cohort studies. First, let's talk a little bit about how each of these studies can be characterized with respect to time. So cross-sectional studies typically involve a snapshot or one moment in time, and that horizontal arrow represents the fact that it's just one moment in time. Case control studies typically involve looking backward in time, and so that arrow to the right is going in the opposite direction of the broader time arrow on the right margin. And then prospective cohort studies, signified by the A, are actually studies where participants are followed forward in time, whereas retrospective cohort studies are ones in which participants have factors measured, in some cases, after an outcome has occurred. So we'll talk about all four of these types in the next few slides. The first type is a cross-sectional design. And as I mentioned, it's really a snapshot. And all of the analysis is done with measures and, in some cases, outcomes that are assessed in the present. And that's signified on this schematic. The idea is to try to find a study sample that's representative of the broader population, represented here by the circle with the dotted line around it. And the investigator first selects a sample from that population and then measures predictor and outcome variables. And then oftentimes those predictor variables are based on the presence or absence of a risk factor. And then the outcome variables are based on the presence or absence of a particular disease. And as an example of a cross-sectional design, again, our same research question that we've been using related to physical activity and heart failure. Our hypothesis might be that lower physical activity leads to a higher likelihood of heart failure hospitalization. And a potential design to answer this question would be a one-time random telephone survey of heart failure clinic patients inquiring about their physical activity and any hospitalization for heart failure over the last 6 months. And below that, you can see the 2x2 table with alternating presence of either the risk factor, which is physical activity, and the outcome, which is hospitalization for heart failure. This really does depict the different groups that we are comparing when we look at cross-sectional studies. So what are the pros and cons of a cross-sectional study? Many of the advantages include the ability to study multiple outcomes. You have control over the selection of subjects because you're selecting them in that one moment in time. You have control over the measurements because you're deciding what you're going to look at in that snapshot. They're relatively short. They yield prevalence data, so you can see what proportion of a group have a particular outcome of interest at that given moment. And it also helps to define demographic and clinical characteristics of the study population. The disadvantages, on the other hand, include a difficulty in establishing causality because everything is occurring in that one moment of time and you don't have the benefit of establishing a temporal relationship to know that factor A led to factor B. It's not really well suited for rare diseases because you would need to sample a very, very large number of people to get an outcome that tends to be more rare. You're unable to measure incidence because you would need some time frame in order to look at the occurrence of a particular outcome over some span of time. And then there's potential survivor bias. So if you're looking at any outcome that is associated with mortality, if we're measuring at one moment in time, then we can't do any sampling among people who are already deceased. So we're limited to being able to study survivors. So one other type of study that also takes place at one moment in time is the case control design. In the case control design represented by this pictorial, we start in the present And we identify two different groups. If we have an outcome of interest, that outcome defines our cases. So we find a group with the outcome of interest already, and those are defined as our cases. And then in a different population, we sample a number of people who may be at risk of that outcome but have not yet developed it, and we labeled that group our controls. So we have cases and controls. And in those two groups, we go backward in time and look to assess whether or not they were exposed to some risk factor for that outcome, for the outcome of interest in the past. And a little bit more concrete example may be our research question related to physical activity and hospitalization for heart failure. In this example, we might select a group of heart failure clinic patients who've already had a hospitalization within the last 6 months. And then we might select a number of persons from a different clinic population without a hospitalization in the last 6 months. So the group with the hospitalization would be the cases. The groups who have not had one in the last 6 months would be the control. We'd ask both groups for physical activity recall over the preceding 12 months. And then that would give us an idea about their exposure to the risk factor, which in this case is physical activity. And this is an example of a case-controlled design. While this design is very useful, it has both advantages and disadvantages. The advantages are that it's very efficient for rare outcomes. So if there is something that is rare in nature or a disease outcome that doesn't occur very often, you can identify people who've already had that outcome and find them perhaps more readily than you would be able to measure the frequency of that outcome in a bigger group. So you can use relatively small numbers. It also tends to be relatively inexpensive. You can also study multiple etiologies. So once you have a particular outcome of interest, you can look at a number of different risk factors that both the cases and controls may have been exposed to. And it's often very useful for hypothesis generating analyses. So while it may not definitively prove a cause and effect, it may inform more definitive efforts to try to better assess causality in a particular relationship between particular measures and an outcome. The disadvantages are that it's very susceptible to bias because there's separate sampling of cases and controls. They're being sampled from two different populations, and there may be some other inherent differences in those populations. And then it's a retrospective measurement of exposure variables. So oftentimes you're asking study participants to recall something that's happened in the past, and that is also susceptible to bias. And then finally, you can only study one outcome. So because cases and controls are defined based on the presence or absence of the outcome respectively, you really can only have one outcome in these types of studies.
So these two examples of study designs are snapshots in time of measurements and outcomes. Are there other study designs that follow the study participants over time?
Yes. So these two are very efficient because oftentimes, as you mentioned, they can be done at one point in time, but there are additional study types that actually do follow participants forward in time, and we can talk about those in the next few slides.
Great.
So before we get into the specific types, I want to just talk a little bit about cohort design in general. And it involves following groups of subjects over time. And there are two main types of cohorts. One is a prospective cohort. In this case, a sample is defined and predictor variables are measured before any outcomes have occurred. In a retrospective cohort, a sample is defined and data about the predictor variables are sometimes collected after the outcomes have occurred. And we'll talk more specifically about both these types of cohorts. First, let's start with prospective cohort design. So this schematic represents the prospective cohort. On the left, there is a circle which represents the population, and then hopefully scientists can identify a study sample that's representative of that broader population, and that occurs in the present. And oftentimes there may be a risk factor of interest, and the scientists can define whether or not at the outset of the cohort, whether or not that risk factor is present or absent, and then follow people forward in time. And then to the right, you can see where it says the future. And then in that time period, there can be some measurement of whether or not there has been some occurrence of disease. And that occurrence of disease is analyzed according to whether or not the risk factor was present or absent. And that allows the scientists to determine whether or not there's a relationship between risk factor and disease. In the example that we've been using, an example of the prospective cohort design might be assessing heart failure clinic patients' physical activity via diary recordings, starting at some baseline and measuring them in real time, and then at some period of time thereafter, measuring the occurrence of heart failure hospitalizations among the same group of patients. So that's an example of a cohort design based on our research question of whether or not physical activity is associated with hospitalization rates among persons with heart failure. Prospective cohort studies, like all other design types, have advantages and disadvantages. Some of the advantages include that it's a powerful strategy for defining disease incidence. So because you're following people over time, you can look at the rate of occurrence of some outcome during that time period. You have control over studies, subject selection, because you're recruiting people to be in the cohort at the outset. You can measure the predictor variable prior to the outcome, and that helps to strengthen causal inference because there can be a temporal relationship established. The predictor variables can be measured completely and accurately because they're measured in real time. They don't rely on recall, and they're not prone to survival bias. And you can study several outcomes. So while you may be looking at one risk factor, you can look at any number of outcomes at the completion of the follow-up period to look at multiple relationships simultaneously. And then finally, prospective cohort design yields incidence and relative risk. Some of the disadvantages, it can be very expensive, as you can imagine. If you're engaging people and following them over time, that takes more money. And it may be inefficient if you're looking at rare outcomes, because you may observe people for some extended period of time and then realize at the end that you don't have enough outcomes for meaningful analysis. Follow-up is essential, and it can be quite tedious. And then predictor variables may change with time. So it may require that the scientists not only look at some predictor variables at baseline, but they may need to be measured over time. So for instance, something like physical activity may change as depending on the length of follow-up time, and those changes would need to be assessed over time as opposed to assuming that just the baseline measurement remains static during the entire follow-up time. The next type of cohort design is the retrospective cohort design. And in this design type, we actually start in the past to the left. And again, there's a sample that represents a larger population. And the investigator identifies a cohort. Oftentimes, it's already been assembled in the past. Then the investigator collects data on those predictor variables which have been measured in the past, and then collects data on outcome variables that have been measured in the present. So the most common scenario here is that someone has a research question, realizes that there's an existing cohort that's already been started, and in some cases where outcomes are being measured in the present, and the investigator realizes that the predictor variable that he or she is most interested in has already been measured in that cohort, and he or she simply uses that cohort to answer some research question because all of the data is there. The difference is, unlike a prospective study, the researcher was not there and didn't have complete control over choosing the cohort and choosing the measures, the specific measures, at the outset of the study. Mm-hmm. In this design type, looking at physical activity and hospitalization rates among heart failure patients, we might assess heart failure clinic patients' physical activity via diary recordings that have been done in the past, and then measure the occurrence of hospitalizations measured in the present among the same group of patients after some period of time. And as I mentioned previously, it's often used in a cohort that's already been assembled with a different focus other than the phenomenon of interest, but that cohort still may work to answer that research question. So there are some disadvantages and advantages to the retrospective cohort study as well. Many times it's less expensive because if it's an existing cohort, that it may lend itself to answering some research question without having to start a separate cohort and follow them over time. It's shorter duration, particularly if the outcomes are being assessed or have already been assessed, because all of the data is already available. Some of the disadvantages are related to limited control over both the design of the approach to sampling the population, as well as the nature and quality of the predictor variables. And it's simply because the scientist doesn't have the opportunity to be there at the outset when decisions are made about who's going to be included in the study and how things will be measured. So I want to talk just very briefly about a nested case control design. This is a study design that allows us to look at measurements in the present from specimens from the past. So the most common example is an investigator identifying a cohort with banked specimens or images or other sort of information. So cohort study may exist. Patients may have been in the cohort study for even extended periods of time, sometimes for years. And if there were blood samples drawn at baseline and frozen, nothing's been measured yet, but the investigator has the ability to look at those specimens for particular factors. So in this case, the investigator would identify a particular outcome and define cases and controls based on the presence or absence of that outcome respectively, and then use those bank specimens or images or other information to identify whether or not a risk factor was present or absent in sort of the same way that a traditional case control design works. The difference is that these cases and controls actually do come from the same population. So it's a little bit of an advantage over the traditional case control design. The advantages and disadvantages here, very similar to the pros and cons of case control study, but with the nested case control, it's useful for costly measurement of certain variables. So if there are, for instance, banked specimens of blood, rather than doing these sorts of measurements on the entire population, instead it can be done on a subset of the cases and a sample of the controls, making it less costly than doing the entire cohort. It preserves the advantages of the cohort study and avoids potential bias from inability to make measurements on fatal cases. And again, in this case, drawing the cases and controls are drawn from the same population rather than a different population. The disadvantages are all of the same advantages that we talked about with other types of cohort designs. So we've talked a lot about more observational studies, and I want to talk about the randomized controlled trial. So the main way that these differ from the studies that I have described thus far is that in the randomized controlled trial, we are actually intervening in some way and then measuring the impact of that intervention. And in this pictorial, you can see that the investigator in the present selects a sample from the population, measures some baseline variables, and then randomizes participants to either an intervention or no intervention, and then measures the outcome variables during some designated follow-up period with the presumption that there is some blinding to group assignment. In other words, in the most ideal scenarios, neither the participants nor the scientist will know which patients have been assigned to which group. And an example of a randomized controlled trial in the context of physical activity and heart failure may be that we'd randomize heart failure clinic patients to either a structured physical activity program, this would represent our intervention group, or usual care, this would represent our control group, and then assess for hospitalization rates over 6 months of follow-up with the research staff assessing outcomes being blinded to treatment assignment. And there really is one primary advantage of randomized controlled trials, and that is the minimization of confounding and co-interventions, and we'll talk a little bit about that. This table on the slide represents the same sort of cause and effect explanations that we talked about earlier. So in the first example, with chance being the explanation, the strategy to try to minimize it in a randomized controlled trial is the same as what we would use in observational studies, and the same is true with bias. Essentially, in our study design, we would try to set things up in a way to minimize interpreting some spurious association either due to chance or bias as a true cause and effect relationship. In terms of the potential for an effect-cause relationship, this really isn't possible in a randomized controlled trial because we have the ability to follow people forward in time. So we, generally speaking, know that the outcome hasn't occurred before exposure to the intervention. And with regard to confounding, we know that the randomization is a chief strategy to mitigate confounding. While we may not know what every potential confounding factor is, we do have the reassurance of knowing that whatever they are, they should be equally dispersed within the two groups, the intervention group and the control group, because people are assigned there randomly. And then with regard to post-randomization confounding via co-intervention, so this means that if somehow there's something associated with the intervention that those participants are exposed to that is not associated with the control group, and thereby the control group is not exposed to, the blinding helps to mitigate bias from co-intervention because the participant in many cases may not know their treatment assignment, and the research team assessing the outcomes may also be blinded to treatment assignment. And both of these things help to minimize bias due to co-intervention. And so hopefully at the end of the day, we end up with what mostly is a cause and effect relationship as opposed to any contribution from those prior four explanations.
Why do we need clinical trials?
So clinical trials are very important because oftentimes they provide us with definitive answers, as opposed to observational studies where we're looking at relationships and we can draw some inferences, but oftentimes not definitively as we can with randomized clinical trials. We also need them to minimize selection and compliance bias, which are both prone to exaggerate benefit. The control group gives us a real comparison group to measure the impact of an intervention. For safety reasons, the controlled conditions of an RCT allow us to also look at safety at the same time that we look at efficacy. As I mentioned, can mitigate the impact of unknown confounders. We also have the ability to study some unknown phenomena in the most ethical way possible. And finally, we hope that these results would be more generalizable and hopefully to all populations. In addition to clinical trials, we also utilize meta-analyses, and this allows us to combine data from multiple studies to answer a research question. It allows us to look at the overall estimate of all studies in aggregate, and the validity of meta-analyses really does hinge on the criteria that are established. It is prone to publication bias because oftentimes negative studies aren't published. So if something's not published, it may not be included, those results may not be included in a meta-analysis. And standardization can be difficult because there may be a fair amount of variation in the way certain studies were conducted. But there are heterogeneity tests to give us an idea about how different the methods or study designs were, and that influences our ability to draw conclusions about the results of the meta-analysis.
So Dr. Durant, you've talked about a number of different study designs. They all have advantages and disadvantages. How does the scientist decide which design to use?
Sure. So that is, of course, the very important question. And there are some people that have established hierarchy of study designs based on the type of study. And this table actually depicts a hierarchy of study designs. On the left, you have the type of study. On the right, the suggested best type of study design. So for instance, when evaluating a particular therapy, the randomized controlled trial is thought to be the gold standard of study designs, followed by cohort, case control, and then case series. Case series essentially are case reports whereby a researcher might describe in depth one or two patients that exhibit a particular phenomena. So it's a very small scale observational study. The same is true for etiology and prevention studies. The hierarchy is identical with randomized controlled trials being at the top of that hierarchy. One thing that you'll notice is that for diagnostic studies, there needs to be a prospective blind comparison to a gold standard. This could be done in the context of a randomized controlled trial, but I think the important thing is that it has to be blinded and there has to be some comparison to a gold standard. And the same is true in looking at studies revolving around aspects of the clinical exam. I think one thing that's interesting here is that you'll notice for prognostic studies, the cohort study actually is at the top of the hierarchy. And this makes sense. If we want to see the natural history of some disease, chances are we're not going to be able to randomize one group to the disease versus not, and then make some observation of the outcomes, particularly in some cases if there's a long horizon between a particular predictor and the outcome. We are limited in our ability to conduct randomized controlled trials for very extended periods of time. And then there are other instances when randomized controlled trials just aren't ethical. If we want to look more granularly at certain relationships such as the volume of tobacco use as it relates to heart disease, clearly we're not, at this point in time, we're not going to randomize groups to smoke a certain number of cigarettes per day and then measure the occurrence of heart disease. So in cases like this, we really are relegated to looking at observational or cohort studies to try to answer those sorts of questions.
And that kind of goes along to how are studies designed to work with community participants?
So with regard to health disparities research, many times researchers will find themselves needing to engage community-based populations. In so many instances, the patient population in academic health centers or in large research centers may or may not be representative of the broader population, particularly as it pertains to population subgroups such as racial and ethnic minorities or gender or persons with particular disabilities. And in order to engage these populations, researchers have to go outside of their academic centers or large research institutions and really work with these communities in what should be collaborative relationships. And community-based participatory research really does describe the process of establishing those collaborative relationships between academicians and community-based entities so that both parties can be involved in the every aspect of the research, from conception, design, implementation, and dissemination of results. And within that partnership, both entities have to acknowledge and make the most of the unique assets that each brings to the table. The table on this side sort of outlines many of those principles that really do define community-based participatory research.
And I also want to refer people to Dr. Monica Baskin's video and health research talk on community-based participatory research.
Yes, this is, needless to say, this is a very brief overview as it pertains to study design, but it's most deserving of a full talk, so I hope that you all will view that talk as well. I'm just going to touch on this slide and just some of the differences between traditional approaches and community-based participatory research. On the leftmost column, you'll see different research phases, and I'll just go through a couple of these examples of how the research phase differs based on the traditional approach versus the CBPR approach. So for instance, in the formative stage, a researcher might plan a project and form a team that would include essentially other research or healthcare professionals. In the traditional approach, in the CBPR approach, however, the community and the academic partners would jointly plan the project, form a team comprised of both people from the academic sphere as well as the community, and they would develop a shared mission and decision-making structure. And to choose another as an example, in dissemination of findings, in the traditional approach, scientists typically publish scientific papers, they make presentations at scientific meetings, but these typically are limited to very academic audiences. In contrast, in the CBPR approach, the community and academic partners are co-authors, they are co-presenters, and they disseminate this information not only to academic audiences, including researchers and clinicians, but it also would be shared with participants, the communities that were involved, and hopefully policymakers as well. And so these are just two examples. This table lists more for your review of how the approach differs depending on more traditional approach versus CBPR. And then finally, this slide lists some of the potential benefits of community-based participatory research. And the benefits really are accrued at every stage. The formative stage, study design, funding, implementation and analysis, dissemination, translation, and sustaining. And it's particularly important to emphasize the sustaining piece because the most ideal outcome from a study conducted using community-based participatory research would be a sustainable change that's made in the community. It's always nice if the study can be designed and conducted in a way such that if something is found to be beneficial, then it can remain in the community or in similar communities where it was tested for the benefit of folks living there.
Yes. This has been an excellent summary of research methods and design, and I appreciate the informed, in-depth information that you've provided to us, Dr. Durant. Thank you very much.
It's been my pleasure.
Great, thank you. And this video and all the health research talks are available on the NRMN website. Thank you for watching this health research talk. We encourage you to email us with any questions or comments. Also, please take a moment and complete the brief survey on the link on your screen. Let us know what you thought about it and how we can improve it for the future. Lastly, register on the NRMN website to sign up for the online mentoring and be a part of NRMN, the National Research Mentoring Network. Thank you.